guys, welcome back to my channel. Today we'll be talking about, can you guess? Have you guessed it yet? Surgery! So today in the video we'll be talking about surgery, what to expect during your core rotations, what was the typical day-to-day, as well as how to study for your shelf exam. So Raj University School of Medicine requires surgery to be 12 weeks. I know some schools, they only do like 8 to 10 weeks, depending on what school you go to, but Raj requires 12 weeks total for your surgery core rotation. I actually had surgery prior to internal medicine, and I honestly think the best way to have surgery is to have surgery like on your schedule is after internal medicine residency. I know you probably cannot like change. I even tried to change it myself to get it switched from internal medicine being first and then surgery, but they're like, no, like that your schedule is set and done, that's it. Just because with surgery, majority of the questions come from internal medicine. And so if you're coming to general surgery, you kind of have to know a good deal of internal medicine on top of surgery. So I would have preferred to have the foundation of internal medicine first to then learn surgery afterwards. Just because, I mean, even when you think about it for residency, a lot of people in general surgery will still do like a transitional year for internal medicine, even before they go into a categorical program, but some people just go into it. But either way, a lot of people, the basis of general surgery is medicine. So at least my opinion it is. And the way the questions were for Uworld, as well as all the shelf exams, a lot of the questions are, you have to know the basis of internal medicine prior. So for surgery, I was working my butt off. So I was basically my day-to-day. So I had 12 weeks of general surgery. Let's see, 12 weeks. Hold on. I'm not the greatest at math. Hold on. For 8 weeks, I had trauma. And for 4 weeks, I had general surgery. And trauma is basically when, you know how like on the emergency medicine TV shows, when a person has like a car crash and their arm is falling off, or they need emergency surgery. When the trauma bell goes off and who's running down there, you have emergency medicine nurses, and you have trauma surgeons. So we would get a lot of basically calls throughout the entire day. And no matter what you were doing, if a trauma bell went off, you ran to the trauma bell. So in multiple times, it could be trauma bells just going off multiple times, depending on like what was going on. Like there was a really bad a car accident, or some people coming in through the helipad. You had to go to that trauma bell too. So yeah, trauma was, I saw a lot of stuff during trauma. I mean, I saw gunshot wounds, I saw like stabbings, I saw like emergency surgeries, car accidents, people working like in construction, having really bad accidents during construction. So I've seen a lot of stuff in trauma, and basically how it worked was, so with each day in trauma, like I said before, you have to go to all the trauma bells. The rounds started, I believe, at like 6 a.m. Like I had to be at the hospital every morning at like 6 a.m. and they were like ready to go. It wasn't like in internal medicine where you get there to pre-round before your actual rounds at 7 a.m. or 8 a.m. They were already doing the cases that came over overnight at 6 a.m. So I was waking up at like 5 in the morning every day just to get to the cases to read in the morning what was going on last night, the night before, if I wasn't on call. So basically I wake up at 5 a.m. and then at 5 a.m. get dressed, throw some scrubs on, take a shower, go to the hospital, and be at basically sign off at 6 a.m. And then after sign off, we would start rounds in like 15-20 minutes. So we would go run downstairs and go get like apples or some type of fruit just so we can eat really quickly before rounds started at 6:30. And then we started rounds was basically, it was rounds that had basically your attending, all the residents, the medical students, the pharmacists, as well as and the nurses. So it was very like integrated. So we would start in the ICU and then go up. So we see like the ICU cases that came in, and then we call us med surge as well. And then in the ICU cases, we had a lot of the trauma surgeons as well as the general surgeons, attendings, and the medical students, and we had to present. Now, when I say you present, it's a lot different from internal medicine. Internal medicine, you give like, hey, this person's a 35-year-old female with significant past medical history of diabetes, hypothyroidism, osteoporosis, coming in for low back pain, onset 3 days. They don't want all that. They do not want all that for their presentations. First of all, they don't want all that extra stuff. They just want to know why they're there. And when you present, they go by system. So whatever is going on in the heart, you do whatever's going on in the heart, their physical exam, what was their findings, what was their vital signs in the heart, things of that nature. Then you go down to the neuro exam, the GCS scale. What is their vent settings? Are they on any medications that mess with neurologically? And then you go down, then you go to the assessment and plan. So that was a transition for me, because in medical school, you get all this information. And I think it's very valuable. And they used to tease me all the time. Now I think about it. They used to be like, Sherry, this is not internal medicine. What are you, internal medicine doc? And I used to be like, because I would have so many details, and they were just like, we don't care. It's not that they don't care, but it's like they want to focus on what's like going on right now, and what exactly they need to fix and stuff like that. So they just had like that, and I was like, oh, this is that, blah, blah, blah. That's great, but we don't really need all that. They used to call me internal medicine all the time because of that. So we did rounds to about maybe 8 o'clock, 8:30. And then after that, we basically wait for trauma bells, and we would see any other consults that was coming in. Like, say, for instance, internal medicine had somebody and they had a sacral floor decubitus ulcer and it needed a surgical debridement. We got called for that. So they would text the resident will text me, or if I'm standing right next to him, he or she, we would go down to go see the patient, go interview the patient, do the physical exam, and then talk with our attendings to see, in this case, if the patient needs surgical debridement or not, or if we also need to consult ID to get them on the correct antibiotic regimen. So that was basically what we did all the way up till maybe like 3 o'clock. And depending on what attending I had, they had clinic days. So sometimes those clinics can run from 1 to 5, or sometimes 1 to 4 o'clock, depending on how many patients they had. And in addition to that, the clinic wasn't every day. So sometimes I would get there at like 5:45, and I would get off at 5:45 in the morning and get off at 3. Or some days I would get there at like 5:45 in the morning and won't get off until 5. And depending on how your institution does it or your attending is, you're also on call. So I took all the calls. I didn't care. I know that I didn't want to do surgery, but I wanted the experience. And like I said before, I always give 150%. So every time my attending was on call, I was on call, and I was very, very tired, but I learned a lot. So, and the more you experience, the more you're able to see things. You're able to basically pick from those things and take that on with you later on when you see that same patient when you're a physician. So I wanted to be exposed to many possibilities as I possibly could. Like whether we got called in at 3 o'clock in the morning for a gunshot wound, or we got called in for 1 o'clock in the morning for a car accident, or we got called in morning at 4 o'clock in the morning and this person got stabbed, and we have to also be ready to do sign out at 6 a.m. and then I go home after sign out. I didn't care because I paid to be here and I want to learn. So I stayed there. I was at the hospital a lot during surgery. And of course, if you're on call, you get post call, you have that day off. So I like that too. I rather just hit the ground running and just stay there, do what I need to do. And the next day I'm off. Like, you know, that's how I like to do. So that was basically that. So we had, so basically overall for trauma, it was from 6 a.m. to about 3 p.m. and then, or 6 a.m. to 5 p.m. depending on if you had clinic or not. Clinic for me wasn't every day. It was depending on when my attending had clinic. Sometimes my attending had clinic once a week. Sometimes my attending had clinic twice a week. And then that would basically be between 1 to 5 p.m. And then while we were in clinic, which I forgot to say earlier, is basically just like any other clinic. You walk in to see the patient, you talk with them, whether if they're coming in for, say for instance, they may have a hernia. Because the trauma surgery was mainly during the day, but the clinic was like general surgery. So we would see things like hernias, inguinal hernias, hiatal hernias, GERD. We would also see like diverticulosis, or what else did we see? We saw a lot of hernias, or a elective cholecystectomy, which is basically take out the gallbladder, jaundice, I mean, basically anything pathological that was in the GI tract, that surgery I saw in clinic. So basically with that, I would go see the patient just like any other clinic, ask them why they're here and if they have any changes in their medications or allergies. And then I would present to my attending as well as the resident, and then we'll go in there together and then we'll talk about the plan. And then while I'm presenting, they can say, hey, you did a good job, or hey, that wasn't that great, try again. And what type of physical exam sign was this, what you did? What is that name? What a differential diagnosis for that? I mean, surgery is, you gotta be all there because they're gonna be on you. But so that was basically clinic. And then the last 4 weeks was general surgery with Dr. Patel. Dr. Patel, he was awesome and he's super, super smart. So yeah, so during general for him, he had a pretty good schedule. So basically he only did surgery twice out of the week, I believe. On Tuesdays and Thursdays was his surgery days from like 8 a.m. to 2 p.m. was around that. But we usually finished around 12. And then on Monday, Wednesdays, and Fridays from like 8 a.m. to 12 p.m. or from 8 a.m. to like 1 to 2 p.m. we had clinic. So he had designated days for just surgery. And if, of course, if he was on call, we would have to come to the hospital to, you know, be a part of the surgery. For him, he basically rotated with other physicians. They had their own rotation schedule with the hospital, so he wasn't on call as much. Versus when I was in trauma, I was always on call. But for him, I wasn't as on call as much, and he had more of a like, to me, he had a better schedule than trauma surgery did, because he had a couple of days where he did just clinic, and then he had a couple of days where he just did surgery, and that was all he did. And of course, on call, if we were on call, then he was do that surgery. So, I mean, I saw a lot of things with him. Like, I saw a lot of robotic surgeries, like with hernias, hernia treatments, where there's inguinal, or if it was abdominal. And then if, say for instance, if they had like now we don't do bariatric, he does not do bariatric surgeries, so he doesn't do that. You have to do that like gastroenterology or specific gastroenterologist surgeon. He doesn't do that, but I saw a lot of hernias, abdominal hernias. I mean, so many hernias. He did a lot of robotics. I also saw like gangrene, and basically very close to necrotizing fasciitis, abscesses. I saw elective cholecystectomy. Like I saw a lot in his as well. And for him, he used to make us do questions with him before the end of the day. So we'd go through Uworld, and I really, really loved that, because my thing is I want to know how you think. I know how I think, and I'm pretty sure it's going to be wrong, but you've been in the game a lot longer than I have, and you know a lot more than I do. So I like to listen and hear how he thinks, as well as other attendings, because they know so much. I can literally read one sentence off of a question, and he can already tell me the diagnosis, the treatment, and the management based off one sentence. And a lot of attendings can do that because they've been in the game so long. You've been doing the same thing over and over and over again. You start to gain that experience. You know a lot. So I really appreciated him giving that opportunity for us to actually just sit down as a group and just do questions, which also helped me with my shelf exam as well as my sub-2CK. So that was basically my theme for trauma and general surgery. Now time for some flashback videos. I'm tired because I feel tired. I've been up since like 4 this morning. Tired. I haven't gotten anything done, but at least I got to sit on the surgery. Have one more to do, one more surgery that got moved. So hello. I'm on call, 24-hour call, and I'm struggling, and I'm just gonna take a quick nap. Hopefully no traumas come, because if they come, just please don't get a motor vehicle accident in like the next 15 minutes. I just need to like close my eyes for just like a good 10 minutes. Okay? 10 minutes.
ETA, 10 minutes.
It's hard when there's no patients, and it slowed down a lot in the past 3 hours, and that makes it harder to stay awake. And I'm trying to stay awake, because if I fall asleep, I won't be waking up. So oh boy. Sorry.
She studied bustanotics.
To your regular scheduled programming. I sound like crap, okay? And I'm on call today. Such joy. Happy Monday. The way I studied for this shelf exam is I read this book, which also a actual surgery resident. He was really nice. He went to Morehouse and he told me about this book. And this book is, I'm telling you, it goes in order of like table of contents. You have like, excuse me, I know I wasted like some oil or something. I don't know. Okay, that's how you know I've been using this book. So it goes in order for like acute surgery, and it goes into like nausea, vomiting, and then they'll go into like different things of that nature. It kind of smells like peppermint. Yeah, it does smell like peppermint. I bet you that's my peppermint oil. But anyways, and so they give you a synopsis of like, oh, a 65-year-old comes in, blah, 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 blah. And then they'll say, what is the differential diagnosis for a groin mass? How is the differential diagnosis in men and women? And then they ask, what is the pathophysiology? And then they tell you. And then like, what's the difference between reducible and incarcerated hernia, and how can you tell the difference? So which one is emergency surgery? And then they tell you. So I really liked it. It was like a question answer book, but it also helped you like figure out what was going on. And it basically does all the cases. Like every case you could basically get in general surgery is in this book. So I highly suggest reading this book as well as doing all the Uworld questions. If you can, try to do the Uworld questions for internal medicine, as well as at least the internal medicine gastro and the internal medicine cardio, internal medicine gastro, especially because general surgery is GI. So if you can get at least those internal medicine questions, the cardio and the GI will help you a lot, as well as the Uworld questions just for surgery. And of course, I did all the MBMEs for general surgery. I did all of them, anyone I could find, I could basically did those. I always max out my questions because the more you're exposed, the more you are experienced, and the better chances of you to answering the question right. So take your time. It's going to be, surgery's a lot, but it's very doable, and you learn a lot while you're doing things, which is what you'll soon to find out, that in third year, you'll learn more while you're doing more things and being experienced and exposed to a lot of different things versus just reading. And especially with general surgery, since you'll be seeing it a lot, it also helps basically put everything together. So I hope you enjoyed that video, and I hope that answered some of your questions to give you a better insight about my surgery core rotation between trauma and general surgery. And I'll see you guys later. Bye.